of rural health services, most of the institution, the health institutions in Nepal, they fall under the municipality. Okay, so and that process has to be assessed before we try to implement any project. Okay. Then again, assess current patient health record system. So what is to be done, what is to be required, and what will be the workflow process, okay, and so on and so forth. Then again, access and review current health programs that are offered by the certain health institutions. And then we think of development, customized and open source, because we're trying to, in our project, we're trying to implement the open source EHR system, because like when we think of rural areas, and when we think of the paid services that might not be financially viable in the long term. So we focus on the open source system, which are widely available, and it's a little bit of customization in very low cost. Then again, coordinate user acceptance with medical staff and municipality administration. Then we have to think of knowledge-based training, okay, training and continued medical education opportunities for medical persons. I mean, this is one of the prime thing that we learned during our implementation process. What is happening is like, the doctors in rural areas, okay, they, after passing out the MBBS, they always try to do MD. Okay, so during that process, they are not able to access the education material and so on and so forth. Okay, that's where the digitization of the knowledge repository system works, and of course the system management, training for electronic health record, and data health, health data sensitization. I mean, that's very much required, because on one of our experience, what we came across is we implemented the electronic health record system, but next day we found out that nobody's interested to fill in data. Okay. So before we implement that system, after doing all this analysis, we failed in that project. I mean, because we could not sensitize the data collection process. So that's again our learning thing. Okay, so that's it. I mean, should you require any clarification, I have my colleague, Mr. Abhimanyu, so he'll be assisting you, or you can write to me directly, pavan.s@ict4dnepal.org. Thank you.
Thank you so much, Pavan sir, for your presentation. And indeed, for an efficient use of digital healthcare in Nepal, we still need to sensitize each and every level. Next, we have a presentation from Professor Dennis Batangan. Professor Batangan is associated with Antonio de Manila University. He is the Research Associate and Program Director there. Today, he is going to present about digital public goods and smarter local health information systems.
Yes, thank you, Dr. Puja, and good day, everyone. I just uploaded my slide, so I hope it's coming to your screens. No, but as a backgrounder, I would like to inform the group that this presentation is part of the work that we're doing with the Ateneo de Manila University, where I currently am connected with, and also with the Better Health Program of the United Kingdom Foreign Commonwealth Development Office in the ASEAN, of which there's an implementation process ongoing in the Philippines. So the title of my presentation is Digital Public Goods and Smarter Local Health Systems, City-Level Integration in the Philippines. The presentation will have these three main parts or areas. I will provide an overview of the digital public goods, and of course the Philippine digital health landscape to provide the context for the overall presentation. Then I'll discuss implications of further local autonomy, which is a recent development in the Philippines, to digital health in our country. And then I will present an evolving model for local health information exchange, which we are co-developing with local government units as as a support, no, for their universal healthcare implementation. On your right is the map of the Philippines. No, it's one of the countries in the Association of Southeast Asian Nations. It's a archipelago of more than 7,000 islands in a population of more than around 105 million people. There are around 80 provinces that comprise the country, divided into three main geographical areas, Luzon, Visayas, and Mindanao. The experience that I will be showing later is in the area of Mindanao, in the southern Philippines. So what are digital public goods? Now, this is it's quite a simplified definition of digital public goods, which came about because of one of the initiatives to support the Sustainable Development Goals. It says here, no, in this slide, no, it just connects, no, digital and public goods, meaning digital technologies, which includes electronic tools, systems, devices, and resources that generate, store, or process data, and public goods, meaning these are commodities or services that is provided without profit to all members of society, either by the government or a private individual organization, which is to the benefit of the well-being of the public. So this particular digital public good initiative, as I said, was directed to support the SDG, particularly SDG 3, good health and well-being, SDG 5, no, and SDG 9. Here in this particular slide, we see examples of digital public goods, and Mr. Pavan actually mentioned about the HIS2, which is actually one of the digital public goods that's already sort of, in a sense, recognized. No? And then we have here Primero, which is another digital public good. I think this was developed by UNICEF, no, intended for social welfare, child protection, and gender-based violence sectors. And the third one, as an example of a digital public good, is MOSIP, which is actually a platform that's being used now for ID systems. No, I think the example in India, in one of the states in India, wherein there was a national ID for the entire state, is one of the models that's being promoted, no, with the use of MOSIP. Well, in the Philippines, we started a few years ago a national ID system project, and we're using actually the MOSIP platform. What are the characteristics of digital public goods? I won't go into details because I know we have very limited time, but I'll just run through them. Adaptability, it avoids vendor lock-in, it's scalable, it's adaptable, there is a venue for collaboration, sustainability, country ownership and capacity. I think this is one of the main features that it promotes, no, transparency and accountability with regards to the software. Going now to the universal healthcare, no, context in the Philippines, no, because we would like to tie in digital public goods with the implementation of the health information system components or provisions of the universal healthcare in the Philippines. So, as you will see here, no, this is the vision of universal healthcare in the Philippines. What I'd like to highlight here is the role of e-health in the implementation of universal healthcare. What it says here is ensure generation and use of evidence in health policy development, decision making, program planning, and implementation. A very salient feature of the universal healthcare implementation in the Philippines is what we call further autonomy or further decentralization, wherein the central government, represented by the Ministry of Health or the Department of Health, is actually supervising or assumes more of a supervisory role to the local government units, represented here by the provinces and cities, such that you see here the dotted lines, no, from the central government to the local government, and the city administration will have to implement their health system, local health system, through using a broad citywide health system policy and plan, and also at the province level for province-wide health system. So this is one of the features of our universal healthcare implementation in the Philippines, which actually provides for more local autonomy in the implementation of the health program. So how is the country preparing, no, preparing for this, because it's a very tall order, not to do this localized implementation of your local health system. So what it did in, I think 2 years ago, it did a what we call a local health system maturity study or survey, and it identified several key result areas for this universal healthcare integration in the respective local government units. There are several key resort areas, and I would like just to highlight the role of information management system in the implementation of universal healthcare, for which there are several indicators that were assessed for these local government units, and they were given with a scorecard, no, which looks like this, so that they would know which part or which KRA they are actually lacking or they need to strengthen their systems. And these are the, for the information management system, these are the key result areas. Highlighting here, no, the role of the EMR system, which was also briefly described by Mr. Pavan, no, the electronic medical records. But in this case, this is expected to connect now to a network, so that the secondary and tertiary providers can be connected through the province-wide and city-wide health systems, such that what is evolving now in this further local autonomy and implementation of universal healthcare is a more localized implementation of health information systems, leading to what we call local health information exchanges, which will try, or which we in the process will now integrate the elements of the Philippine ID system, the Data Privacy Act, COVID-related issuances, other issuances related to universal healthcare implementation. What you see here on the left, PHI is the Philippine, or it's the National Health Information Exchange. Now, with this development of further local autonomy and further localization, what we are seeing is that the local government units, meaning provinces and cities, will have to develop now their own local health information exchanges. This is the open HIE architecture, which you probably are very familiar with in terms of the health information exchanges. This is a very generic model design, no, that's being used. The key here is that there are authoritative registries, what you see on the left, and an interoperable layer, which actually intermediates, no, between the registries, the applications, the facilities to be able to generate the reports. So this is essentially how OpenHIEs operate. What I placed here is that this particular prototype is now being adapted, or has been developed, no, for pilot implementation in the Philippines, and we are now in the phase of actually integrating more softwares into the interoperable layer. One of the softwares that we will be integrating probably latter part of this year is a mapping tool for NCDs, no? Because we noticed that the NCDs are lagging behind, no, in terms of the digital health interventions or participation in the e-health system. So with the work that I'm doing now with the UK Better Health Program, which is essentially focused on the non-communicable diseases, we developed what we call a local multi-program local mapping tool, which is specific for NCDs. No, so this is how it looks like. No, this is how the dashboard looks like, and I won't go into the details, but it's just describing to you that it has a dashboard, which I showed earlier. Sorry. And it has a patient registry for database for list of patients, no, for diabetes, hypertension, cancer, chronic respiratory, mental illness, and the visits of these particular patients are actually the risk assessment done and visits done by these patients are actually recorded in the system, and it generates reports that are needed by the local facility, the local government unit, and also the regional offices of the Ministry of Health and the Health Insurance Office. As we were developing this software for NCD recording and reporting, we also developed additional features which are listed here at the bottom. One is a vulnerability profiling list, which it's like a electronic triage for identification of the most vulnerable members of the community. And we also have a DQC, data quality check feature, which identifies duplicate entries in the system, so that it can be corrected early. So what I'll be describing in the last few slides is actually a prototype that we are developing in Cagayan de Oro City, which is one of the highly urbanized cities in the Philippines. It's in the southern part, in Mindanao group of islands. So you see here the map, and it's actually in the northern part of the island. It's one of the more progressive cities in the country, and it has won several awards, including this Galing Po Award, which is recently won, and of course the e-government. But what I'm trying to highlight here is that the approach to digital health interventions should actually relate, or anchor, or coordinate, or collaborate with the other initiatives of the local government unit, particularly those relating to electronic governance or digitalization on a broader scale within the city. So this is how the system now is customized for a city. This is now evolving as the local health information exchange for the Cagayan de Oro City. It's called the Smarter Integrated Local Health Information System. So using the open HIE design, we developed a platform, an electronic platform, which connects the pilot sites of 2 health centers. Here we have the Tablon Health Center and Carmen Health Center, which are 2 health centers within the city. The city hospital is called the J.R. Borja City Hospital, and the regional hospital, which is the apex or the referral hospital of the city, which is the Northern Mindanao Medical Center. So what happens is that the different electronic health systems in this particular facilities actually participate in an interoperable initiative, and actually use a common technology, a common platform called the HL7 Fire. And through that particular common technical solution that everyone has adopted, be able to communicate with each other for patient referrals or other services that they need to provide to their constituents. At the same time, we have already identified other softwares, aside from the ones that are being used. Particularly, this refers to the ones that are being used by the private facilities, because the ones that are being used by the public sector are already identified. Now we're actually in the phase of identifying the different softwares that can be integrated into the SMILIS system coming from private facilities. So it's a long process. No, it's not done. In fact, this is a 7-year program that we have started in 2019. So we're now in the second phase of this this program, and we are now actually working with private sector partners of the city. This is how this is a prototype, example of the dashboard, which looks at the number of hospital beds available in the city, which was actually very helpful during the COVID pandemic, wherein the dashboard actually tells the local chief executive the number of beds that are occupied, and number of beds that are open or free to be used within the city on a real-time basis. So what happens actually is the participating facilities will have to provide the information to a common registry, so that the local health information exchange to SMILIS can generate this dashboard for the local chief executives. Yeah, so I think that's the end of my presentation. I hope I didn't go over time with this presentation. So this is actually a presentation on a digital public goods and smarter local health information systems, city-level integration in the Philippines. Just a final note that the SMILIS that I have presented as a local health information exchange is actually being it's being prepared to be nominated to be a digital public goods through the digital public goods alliance of UNICEF. No, so we hope we make it within mid-year, no, to be nominated to the digital public goods alliance of UNICEF. Thank you very much. Good day, everyone, and I turn back the floor now to Dr. Pooja.
Thank you so much, Professor. It was a really impressive presentation on digitalization, and there's so much to learn from you. Next presentation, we have a slight change in our schedule. Dr. Srishti Singh will be presenting from APAN Hospital. Dr. Singh has done interventional radiology from Sun Yat-sen Cancer University and has got distinction in that. And she's the first female interventional radiologist in Nepal. So I'd like to request her to do her presentation now.
Hello? Hello, can you hear me? Hello? Hello, can you hear me?
Yes, yes, please go ahead.
Hello, namaste everyone. I'm Dr. Srishti Singh, as already introduced by Dr. Pooja. Thank you so much. And thank you for allowing me to present a little bit earlier, because our staff over here are a bit stressed because they have to catch the bus for their home. So I'll start my presentation. So basically today my presentation is on intervention radiology, present scenario in APAN Academic of Health Science. So my objective will be brief overview of APAN Academic of Health Science and my current scenario of intervention radiology in our institution. So the basic motto of APAN, PAS, as we call it, PAS. The basic motto of PAS is dedicated to sustained improvement of health of the people in Nepal, especially those who are poor and living in rural areas, through innovation, equity, excellence, and love in education, service, and research. This is our motto. So basically, goals of PAS and intervention radiology are interlinked. So I will first talk about goals of PAS. So basically, it is training technically competent, caring, and socially responsible physicians and of the other healthcare professionals, sustain and upgrading the quality of the current health systems, and giving special consideration to the needs of poor and disadvantaged. It undertakes appropriate clinical, public health, and biomedical research. It is proactively encourage the NHS for appropriate health policies, program, and system to uplift the health of the rural area. The important is enabling deserving students from underprivileged sector of Nepalese society to access health science education, including medical, nursing, and allied health science education. So the country current system of medical education has failed to address the need of healthcare in rural areas. One of the main reasons being unwilling of healthcare professionals, particularly doctors, to serve in Nepal's remote and rural areas. Therefore, our institution is producing doctors each year who are willing and able to provide healthcare to disadvantaged patients living in remote areas. In 2016, PCL Nursing, BN Nursing, Master in Nursing was established. So basically, we are training doctors, nurses from our institution. The role of IR in past linked with rural development is like we are going to train the doctors, nurse, and allied health professional allocated throughout the rotational period in intervention radiology, making them aware about the procedures to be performed, training them for simple procedures such as drainage insertion, biopsy, and FNAC, which is very required in rural areas. So what is intervention radiology? This is new to our country. There are a few doctors already who have done their fellowship and starting in a few centers over here. So intervention radiology is a medical specialty that performs various minimally invasive procedures using medical imaging guidance. We use ultrasound, CT, DSA, MRI, and intervention radiology is an exciting area of more modern medicine delivering precise targeted treatment for complex disease and condition throughout the body. So it is minimal procedure which we do with a small hole, and the advantage of this is it provides high quality care with less morbidity and often at lower cost than many surgical alternatives. IR is practiced across a spectrum from basic procedures performed by the clinical radiologists like FNAC and biopsy to the complex vascular, oncological, and neurological interventions performed by special radiologists. So in intervention radiology, role in medical field is very broad. It is from head to toe. We can do lots of procedure with the help of imaging guidance. So I don't want to explain more. I don't want to put on details because we have very time limitation. So the role of intervention radiology in PAS is we perform FNAC biopsy from difficult sites. We help in immediate diagnosis of patient and early management from biopsies. We put drainage, percutaneous nephrostomy, percutaneous biliary drainage, cholecystostomy, etc. are carried out on daily basis as a palliative, therapeutic, and diagnostic purpose, which is performed with a small hole, as I already mentioned earlier. The patient has the financial burden is decreased due to short hospital stay. Patient visiting from remote places for treatment purpose can return to their hometown within few days. So IR also has played important role in management of traumatic cases, post-procedural complications, emergency management. Here we have oncology and oncology team, which is very strong. So we are doing chemotherapy, line insertion, embolization, we treat central venous occlusion. We can treat fistuloplasty in future. So along with this, we can train medical students. We are training medical students. There are MD residents who are trained in our IR departments. There are other faculties who are in rotation, which we train those individuals. So we work in multidisciplinary team to contribute to the improvement of the patient and proactively encourage the hospital in development of appropriate programs in awareness of the people. We are training students, as I already mentioned. We are enable patients from underprivileged sector of Nepalese society get facilities of interventional radiology in Patan Academic of Health Science. So basically, I'll give the small light on what we are doing. These are the few cases which we have done recently. So this was the patient, 68 years old female. She was a known case of TB, pulmonary TB, presented with frequent bouts of hemoptysis, which was increasing in frequency. Patient was referred to IR. As you can see in the picture, this is the lesion. So this was the lesion which was bleeding. These are the supplying feeding vessels. So we cannulated the bronchial artery with the catheter, and then we embolized these feeding arteries. While doing subsequent injection, there was decrease in flow, followed by stasis, and there was complete stasis. This patient, she had no hemoptysis. Following day, her hemoglobin level was increased. This was a 50 years female referred to emergency with complaint of hematuria. Her hemoglobin was just 6 grams per DL. Patient was referred on emergency basis. So we had to take her directly to the cath lab. This is the CT images. This is the CT images. So this is the CT where you can see this contrast lobulated structure. This is the pseudoaneurysm. It was bigger in size. So this is the volume rendered image. When doing the DSA angiogram, you can see this outpouching over here. These are the vessels, which it should be like this, but this is outpouch vessels. So this is the pseudoaneurysm, which was bleeding. So we cannulated the supplying vessels with the microcatheter, and then embolization was done with the coils. This is the coils which we placed in the supplying vessels. And then, as you can see from the parent artery, we have done the angiogram. The pseudoaneurysm was gone. The patient hematuria was stopped. Subsequently, her hemoglobin was increased. Patient is discharged now. So this is another case, 50 years male with hilar cholangiocarcinoma, presented with yellowish discoloration of skin and urine, Gideon's LFT. A patient was shifted for percutaneous biliary drainage. We put the drain, bilateral drain was inserted on left side and right side, both sides. And then this patient also, his LFT was decreased and patient was improved symptomatically. So this is the another case. This was an interesting case, which this was my first case actually. I kept it because this was the first case in PAS hospital, which I did with the help of all our sisters, nurse, and staff over here. They helped me a lot to bring this, do this procedure, which was very difficult at the initial period of time. She was 30 years female. She had cesarean section. 2 babies was, she had completed her family. She presented after 40 days of delivery, presented with PV bleeding. While doing the CT angio, we saw the pseudoaneurysm, and then we discussed to embolize this patient. This patient was shifted to cath lab. This is this outpouching, as you see. This is the pseudoaneurysm. This is the uterine artery. This was the uterine artery pseudoaneurysm. We cannulated with this. This is the microcatheter over here. This is the major catheter. And then after cannulating, we embolized this case. When we do the angiogram, the pseudoaneurysm was gone. So this is another interesting case we did just a few weeks back. This was a case where patient was referred from outside with the diagnosis of placenta accreta, placenta previa, and previous cesarean section was done. Patient was prone to excessive bleed. So the primary team planned for embolize. I mean, they discussed with us for any IR expertise we can do. So we planned for internal iliac balloon placement. In this case, we shifted the patient to the cath lab. Under very low fluoro time, we kept the balloons where you can see these are the balloons. This is the one balloon, this is the another balloon. We placed it in the internal iliac artery. Patient was shifted to the OT with this balloon in situ. After delivery of the baby and cord was clamped, we inflated the balloon. The surgery was done. Then balloon was deflated after the completion of the procedure. The total blood loss was only 500 ml, which was supposed to be around 2 liters to 3 liters during the procedure. So this was also another successful case which we did in past. So since we have time limitation, I just included a few cases which I thought was interesting to do over here. So in conclusion, currently IR is dedicated to fulfilling the goals of PAS by providing the most advanced procedure for effective management of the patient referred to our center and training the students, nursing staff to perform a drainage and biopsy procedure in remote and rural areas. Thank you.
Thank you, Dr. Srishti. Indeed, interventional radiology is definitely an important part, and that PAS is working on training and developing other healthcare workers in this field. The next presentation is on transforming rural healthcare under leadership of a general practitioner by Dr. Rajkumar Dangal. Dr. Dangal has an experience of working in different remote and rural parts of the country. He's a general practitioner and emergency physician, and currently working as a consultant, lecturer, and clinical chief at Kathmandu University Hospitals.
Hello, namaste everybody again. Thank you, Dr. Pooja, for inviting me. I'm Dr. Rajkumar Dangal, general practitioner working in a rural hospital, Dolaka Hospital under Dhulikhel Hospital. So today I'm going to share some of our experiences, how we are trying to transform a rural healthcare system. So I'd like to start with one of a very real case scenario, how a periodic critical care in a rural setup is possible. So the case summary is full-term, very low birth weight, 1.2 kg baby presents in our hospital, in our emergency, in septic shock on third day of life, collapses in our emergency room. Then baby gets resuscitation with cardiopulmonary resuscitation, then intubated, then baby gets some revival of the signs of life, then baby is admitted in our NICU under mechanical ventilator. Some of the antibiotics, some medications, blood products, they were supplied from our central hospital, and baby finally gets discharged on day 9th and referred to our central hospital for some workups to find the cause of IGR. So here I have kept one question: was the baby just lucky? So if I have to answer this question myself, I say no. Okay, so it's not just a baby lucky. Here, big system, hospital service delivery system has been implemented, has been established with the effort of so many people, so many investments, so many good interests. Okay, so many cooperation and partnerships. So here, I would like to share how we are trying to transform rural healthcare, how it's possible to provide the accessible healthcare system. And just let's give thought with few questions. So can we bring a holistic, multifaceted and specialty healthcare system to rural areas? Isn't it a moral imperative of all of us to provide access to quality and equitable health services to underserved communities? Can we bring up energetic and enthusiastic healthcare leaders to assimilate rural healthcare as primary interest, and thus proudly? Isn't it a time to redefine rural healthcare? So if I have to answer again, I say yes to all these questions, because we can, we should, we have to, and it's possible. So this a model how we are trying to build up, I'm going to share. Okay, so about Rural Hospital, that's our parent institution. It's an independent, non-for-profit, non-governmental institution established in 1996 with the principles of social equity, sustainable development, and harmony of nature. It provides cost-effective, compassionate, and quality healthcare services to thousands of populations and believes in quality healthcare services need not always be an expensive commodity. So the Rural Hospital has developed outreach centers in different parts of Nepal. Outreach centers are a small healthcare kind of setup with 5 to 10 healthcare personnel providing healthcare services, basically primary healthcare services. And there are at least 18 outreach centers throughout country. So there's some examples of outreach centers, how they start and their setup and their environment. Here, this hospital, Dolka Hospital, where now I'm working and I'm delivering the presentation. This is one of first of its kind among 18 outreach centers of Dolka Hospital. It's located on the 30 kilometers northeastern part of the capital, Kathmandu, and this district has around 200,000 rural population as catchment area. Our hospital is 55 bed capacity, second level general hospital with specialty services, and we are providing special services in general surgery, gynecology, obstetrics, orthopedics, pediatrics, and critical care, apart from our other general medical surgical services. So here I want to give you a glimpse of how different facets of services and activities we are performing. Apart from curative services, we have community health programs, we have academic activities running on, research program running on. So for the development of infrastructure, previously there was this another hospital setup, and that has been renovated and new hospital setup has been established. And we envision to develop an exemplary, integrated and innovative community level healthcare, academic and medical research model, so that it will be a model for so many people. We believe, we envision that. And the mission is to provide quality community level health services, incorporating academic, medical, curricular programs, medical, community health programs, innovation and health research programs. So, and our goal is to improve health status of rural community through quality health services, to produce competent medical manpowers, and to pioneer in community level health research through integration of community health programs, digitalization and innovations. So here I'd like to share our some few pictures regarding our setup and hospital and different activities. Registration with electronic health record systems. We have ESR system that's from Mediflow Solutions. So our emergency room and procedure room, well equipped system setup, lab with a good number of laboratory tests available, digital X-rays, OPD, pharmacy with a good number of good amount of variation of medications. Inpatients, we have three different wards: general ward, post-op ward, and maternity ward. Here, maternity ward and with modern delivery room, you can say. Dental department, we have dental doctor also, dentist. We have physiotherapists also, bachelor in physiotherapist. We have USC, at least we have portable USC also at different sites, in the emergency room, in OT, in delivery room, and we are delivering 24/7 USC services also. So I'd like to share some of the statistics, especially regarding last 3 years of developments of hospital. So 3 years back, our total patient flow was 2,500 around for in a year. And the next year it was 3,400 around for a year. And last year it was more than 12,000 patients in a year. So that happened to because of we expanded our services. After I joined the hospital as a MDGP consultant, we started some surgical services and expanded many other clinical services. So basically we have around 1,400 patients in a month. We have teaching learning activities also because this is the outreach hospital of academic institution to the hospital. So we have residents, we have intern doctors, and even medical medical electives also. So that's teaching learning activities that
Dr. Rajkumar, are you there? I think he's having some problem at his end. So until he connects back with us, can we continue with the next presentation? We will try to solve that issue at the same time. So next, I would like to request Dr. Joseng Jang from Republic of Korea. Dr. Jang was here in Nepal until yesterday, I believe, and I saw your very nice picture of Nepal. So he had been working at the United Mission Hospital in Tansen. So over to you, Dr. Jang.
Hello, this is Jaesong Jang. Now I'm share my monitor. Can you see me?
Yes, Dr. Jain.
Now I'm presenting my experience in Tansen municipality for 3 years of Nepal. My family went to Nepal and stayed for 3 years in Tansen. Before that, I did my general surgery residency from 2011 to 14, and 2015 to 16, I got a hepatobiliary and pancreas surgery fellowship training under the Professor Han of Seoul National University Bundang Hospital. United Mission Hospital Tansen, usually we call this hospital Tansen Hospital. This hospital is located about 174 kilometers west from Kathmandu. It takes 10 hours by car. This is the scenery of Tansen municipality. This is the center of the city. However, when we see a little outside, this is the very near place of the hospital. So Tansen Hospital is located in totally rural area. Tansen is a very beautiful place. Tansen's altitude is 1,336 meters over the sea level. So we can see the clouds under our feet. And after monsoon, we can see beautiful Annapurna mountains. However, because our hospital is located in a mountainous area, during monsoon period, we experience so many landslides. United Mission Hospital was established in 1954. almost 68 years ago. This hospital is basically a Christian mission hospital. So you can see that sentence, we serve, Jesus heals. Yeah, this is our belief. Our hospital has 159 beds, and we are working as acute care. So our departments are medical, pediatric, orthopedic, general surgery, OBGY, psychiatry, and recently we started Euro, and we also serve in dental area. Yes, we have so many things, but as a surgeon's viewpoint, I introduce you what we have. We have 3 operation rooms. We can do major operations in these rooms, and the 2 minor operation rooms. Almost 20 to 30 operations are performed every day. And however, the problem is we have only one anesthesiologist. This anesthesiologist is also local guy. So we posted since many years ago, vacancy of anesthesiologist. However, it is very difficult to get a new anesthesiologist. And we also have a HD, high dependency unit, but we are now preparing ICU. So we are doing ventilated care only for very ultra short period. For example, snake bite patient. And we also have a burn unit. And we have ultrasonography and ultrasonography guided central line insertion, and also nephrostomy and intraperitoneal pigtail insertions are performed. And CT scan is not available in our hospital, but is available in near Lumbini Medical College by car 20 minutes. These days we are sustainably providing the service of gastroscopy, colonoscopy, and ECG, cardiac echo, X-rays. And blood tests are basic blood tests are available. And the swab culture is performed. However, our blood culture is very low yielding, so usually we don't do. And for about operation theater, we have one laparoscopic set and TURP and URSL with a rigid scope and C-arm. This is the entrance of the operation theater. I'm sorry, I don't have menu inside of the operation theater. Now I'm in Korea. I'm very sorry about that. So common operations in United Mission Hospital Tansen is of general surgery is most common is IND. So many post cavity patients, post collection, yeah, and necrosed tissue and infected tissue. We should do the debridement and the cesarean section. We general surgeons do cesarean section. Also, orthopedic surgeons sometimes do or have to do cesarean section in Tansen area. And open appendectomy, hernia repair, laparoscopic cholecystectomy, skin graft for burn patient, and hemorrhoidectomy, hydroshield. And because we don't have CT scan, many operations are exploratory laparotomy. We don't do exact diagnose, but we do operation based on ultrasonography report and physical exam and lab report. Usually they are also operation or small bowel operation. And also we do many amputation operation. Left photo is born patient, very young child, young baby. But after healing and operation, we can treat like this. This baby is newborn baby, but with Hirschsprung disease. But the patient was so poor they cannot go to Kathmandu because of their financial reasons. So we had to do operation. After the operation, the patient right side of the photo of the baby looks very peaceful. And this left photo is pus. Daily we remove pus from patient's body, from the head of the from the head to the feet, or anywhere, any part of the body. I found that any part of the body, the pus can collect under the skin. And the right side photo is electronic burn of a 14 years old boy. We had to do a rotation flap surgery. Yeah, as I told you, the baby, sometimes the left photo is hypertrophic pyloric stenosis baby, and right side was malrotation. This baby had to underwent surgery in our hospital because of their financial reason. As I told you, I have learned hepatobiliary surgery in Korea. However, that's why I know very specific area of surgery. But in Tanzania, I had to learn very wide area of general surgery. In Tanzania, I had to learn Nepali language also, and I learned how to do IND, debridement, how to manage infected wound, and also I learned about burn surgery. In Korea, we usually can learn about burn in specialized center, but so I had to learn about burn in Tanzania, in Nepal. So in the future, I hope we can expand our capacity, flap surgery more, activated more specialized skill, and the laparoscopic appendectomy also. We need more devices, and we need ICU care. Many septic patients need ICU care, and we need more operation center. So I wish we will have CT scan and MRI, ICU, ABGA, ventilated care, TPN, IV albumin, alpha-fetoprotein, PSA, anaerobic culture. We need these things to improve our practice. And also, we have many stone patients, gallbladder stone, CVD stone, and kidney stone and ureter stone. So we need ERCP and PCNL. We are already doing URSL, so we need to expand our procedure to PCNL. So we need to buy some disposable laparoscopic devices. Probably some rich people living in municipality, living near a bazaar, they can pay for these disposable laparoscopic devices. But above all, we need more specialists. We need anesthesiologists, radiologists, pathologists. So last 3 years, I had some difficulty living in rural area. So for above all, children's education, probably I cannot come back to Tanzania for a while. I need to educate in Korea or in Kathmandu. And the second was inconvenient life. So this is insect bite of my foot last year. So it was very itching. So this kind of experience was very new to me. Last year and the year before last year, we had the financial crisis due to COVID-19. Tanzania hospital is self-sustaining hospital. We can sustain our hospital without foreign country help, but we can. Because of coronavirus, our number of patients dropped dramatically. So we had some difficulty because of corona. So, however, living in Tanzania and working in rural area is very very pleasing. I teaching my juniors and working with lovely people in operation theater and the fellowship with other doctor families
Hello, Dr. Chang. Again, we are having some technical difficulties today, so I would like to request Dr. Rajkumar to please continue your presentation. Dr. Rajkumar.
Yes, Dr. Puja, yes. Okay, I share my screen, okay. Okay. So can you visualize my slides? Dr. Puja?
Yes, yes, please go ahead.
So I think I was here last time. So for last 3 years, we have seen a very exciting developments in patient flow. So at least 4 or 5-fold patient flow has been increased after we started delivering other health services, especially after I joined here. So monthly, we have 13 to 1400 around average patients flow. And teaching learning activities, I think I was talking on that. I don't know where the connection lost last time. So we have visiting faculties, residents, medical officers, interns taking part in the teaching learning activities. So we started our surgeries with the C-section 1.5 years back, actually. So though we have so many limitations, we didn't have blood bank right here. To early stage to start with a very kind of intermediate kind of surgery can be challenging, but still we started with the help of different departments also by bringing including anesthesiologists, bringing from Dhulikhel Hospital, our central hospital. Then we expanded our surgical services, started with the orthopedic surgery and some other surgical procedures. We included laparotomy for obstetric pregnancy, appendectomy, hernia surgeries in adult and pediatrics, orthopedic surgery, ORI, platings, K-wires, some flap surgery, some large debridement, tendon repair, skin grafts. So I'd like to say some of the cases, major surgeries done here. Say that's the plating done for two different bones in the same patient, arm and forearm bones.
Excuse me, Dr. Sundar.
Yes.
Can you do the slideshow thing for your presentation, if possible?
So
Yeah,
is
thank
that
you.
okay?
Yes.
Okay, so
This is the multiple slide view. There is another feature that says slide view.
Wait.
Dr. Rajkumar, slide show मात्र गर्नु न तपाईको नेक्स्ट पनि आयो के थियो
Okay. Shall I do it again?
स्टप शेयर गरेर फेरि एकचोटि शेयरिङ गर्नु न त
Sure. Okay, so is that okay?
Yeah, this is much better. Thank you.
Slideshow anyway. So some of the other surgeries, some flap surgeries, rotation flap surgeries from orthopedicians, and some other procedures, some sutures, some INDs, some plaster and casts, and like these things in our procedure room. Some other procedures here you can visualize just to show you some of the works. And just want to say one very exciting story of saving a woman with rough-rectal pregnancy in shock. And as I already told you, we didn't have blood bank, but we have to mobilize our manpowers here for getting the blood donation and transfusing to the patient. Another was emergency pericardiocentesis done in a young middle-aged person, basically with large pericardial effusion that was drained. And that's a very critical life-saving procedure done by our team here. So recently we have started the Safe Motherhood program. That's a government priority project, you can say. And we have recently 5 to 10 C-sections in a month, or 9 to 10 to 15 normal deliveries. Okay. So here, so apart from the patients and the communities, we have some other residents or medical officers who are also happiest among them, because they are getting good opportunity to learn and serve the rural community. We have ICU services, also 3-bedded ICU for adults with 3 ventilators and 1 pediatric neonatal ventilator service also we have started. And during COVID pandemic time also, we had good challenges, so good opportunity to serve the rural population also. So we could become able to sort out the different COVID cases and manage them or refer to other centers as possible, and taking their swabs, sending for the other testings to Tolikela or the central hospital also. And we have also established another isolation center also. So we have another community health support program in collaboration with the Possible Health, and it directly deals with the communities. So we have community health workers in at least 4 different rural municipalities around here, and they directly go door-to-door hospital, and they deliver ANC services, PNC services, some nutritional, some other services also. So here, so the home visit and care delivery services in last 4 years has been more than 57,000 home visits and service delivery. So ANC Mothers Home Visit Program has improved the ANC care and maternal side health issues also. Institutional delivery has been increased from 79% to 94%, and home delivery and road delivery has been significantly decreased. So apart from them, we have community approach to non-communicable diseases. We have a community-based rehabilitation that is intended for those with some disabilities. We have COVID vaccine study trial also running here. That's from International Vaccine Initiative. That's a parallel group phase 3 multi-stage modified double-blind multi-armed study. That's from Sanofi Pasteur Pharmaceuticals. So that's also shows up in a rural setting. We are running a double-blind RCT. Okay. So we have mental health services also. That's we are delivering through collaborative care model, and that's with the help of HEAL fellows from University of California. And from our experiences here about collaborative care model, we have published an article also with the different challenges of implementing a collaborative care model in rural setting. Other like dealing with the other stakeholders and delivering other services like health camps. Here you can see some dental camps, some vascular camps, some of the pediatric surgical camps. Last few months back, we did 7 surgeries, pediatric surgeries, hernia, hydrocele surgery especially. Just a month back, there was pediatric cardiac screening camp also. So at that time, more than 400 children has been screened, and a significant number of children was found to have some structural heart disease and required address. And we have some community engagements, like we arrange for pregnant women's conference, where we try to educate them regarding the pregnancy, their complications, their requirements. So apart from that, we also try to reach out of our hospitals. So teleconsultation with migrant workers who are staying abroad. Also we have done. So we are trying to deliver the services, service to humanity, I say. proudly. And we keep on continue serving lives for the rural communities. But here I'd like to highlight, and I'd like to say that that's not that's because of lots of efforts and from different levels, so many investments, so much of big interest, okay, heartful interest and mind of services to the rural population. So here I say I believe in healthcare as a human right, as Dr. Paul Farmer says, and he says injustice has a cure. And we refuse to accept that any life is worth less than others. So here, finally, I'd like to say we can make not only primary healthcare, but also specific care more equitable and accessible, and that's possible, but different challenges are there. We should be willing to address these challenges. Thank you much. Thank you very much.
Thank you so much, Dr. Gangal. It was really nice to see your presentation, except it was a little too long for us. So I would also like to thank Dr. Jang at the same time. He also got disconnected in the end. I really appreciate your work in the rural health care system in Tansen, despite the challenges. So we're moving on with our final presentation. I would like to request Ms. Reshika Paudel. She's working as a school health nurse. Ms. Paudel, can you please share your presentation? And I would like to request you to be short and sweet. Thank you.
Hello, everyone. Hello, everyone. Are you listening me?
Yes, please go ahead.
Okay, let me share my slide first. Is it visible?
Yes, you can go ahead.
First of all, thank you for inviting and participating me to share some information in this program. Okay, now I'm here to present you about the role of nurses in rural healthcare. And before entering the topic, let me share some general information. In Nepal, around 60% of nurses are working in rural areas. As we all know, Nepal is a geographically diverse country, and here, in comparison to the urban areas, most of the health workers are working in rural areas. And among these 60% of nurses, 70% are auxiliary nursing midwives, ANM. The number of ANM is more so as to improve the target based on improving maternal and child health sectors here. And besides this, the working areas, most of them work in local level health posts, whereas some of them are public health nurses who works on governmental offices in the rural areas, and some works in specialized hospitals like districts and regional hospitals, some in primary health care centers, and yes, of course, as a school health nurse. Okay, now getting into the topic, the core role of nurse in rural health care is as a healthcare provider, where their responsibility is to providing healthcare services in preventive, promotive, curative, and rehabilitative health services to all individuals, family, and community in respective fields. And likewise, providing the training, supervising, and guiding the health workers, especially the FCSVs, female community health volunteers, for the delivery of healthcare services at the doorsteps, because in the rural areas, not everyone is able to reach healthcare centers. Likewise, another role is planning the reproductive health program, including family planning programs in coordination with other health workers. Nowadays, like considering the population of Nepal, the family planning program is one of the important program. And next one is the follow-up services, like the follow-up services are mainly carried out by the public health nurses. The follow-up are done to provide to measure the effectiveness of the health services or the welfare programs that are provided to the community. And similarly, the another major role of rural healthcare nurses is assisting in implementation of the national health programs. For example, in Nepal, the national health programs includes national immunization programs, vitamin A supplementation, and deworming program for the children's. And also nowadays the folic acid distribution programs are also being carried out at the school level, where the female children aged 10 to 19 years old are supplemented with the folic acid. And similarly, school health programs include the organization of necessary educational programs. Especially here, we include the educational programs about the reproductive health, and the adolescents aged group children are taught about the mental health issues also. And the school health nurses are responsible to assess the health condition of the children who are reading in the respective schools. And also, not that only, the school health nurses are responsible to provide the necessary informations to the government about the mental health condition of the children, and also the datas. Similarly, to identify the nutritional status of the children, especially aged under 5, where here we are responsible to identify whether they are well nourished or not, and if they are malnourished, then we are also responsible to refer them to the respective healthcare centers. And yes, about the menstrual hygiene program, in the picture also you can see that nowadays the Nepal government is providing the sanitary pad to the school level children to enhance the menstrual hygiene program. And likewise, another core responsibilities and roles of the rural health nurses are carrying out supervisory functions of the home visits around the respective working areas. These are also mainly carried out by the public health nurses, and especially by the ANM, who are working on the respective local level health post. And the next one important role of the nurses is to provide maternal and child health care, where the nurses mainly carried out the antenatal examinations. Besides this, they motivate the maternal and child health care by providing public awareness, and also by giving the management of the management of the labor and PNC complication, postnatal complications, and also provides the neonatal care. And besides this, in addition, I have already mentioned about the national health programs, where the national immunization programs are also carried out by the nurses in the rural healthcare centers. And the immunization against infectious disease is also the another role of the nurses. Under aged 5 children are immunized by the nurses in the rural areas. And similarly, the prevention and control of endemic or pandemic diseases, for this the COVID-19 is the best example. And let me get into the COVID-19 later. First, I will talk about the disaster preparedness and management. As Nepal has already faced a huge earthquake, and in our country at that time we are all known about the vital role of the nurses on providing care to the patients, and also providing prioritizing the patients and uses of the triage and all at that time. And nowadays also some drill acts are being carried out at the rural areas where I am working, so as to prepare for the disasters. And okay, about the COVID-19 outbreaks, the main role of the nurses here is to ensuring that all patients acquire personalized, high quality services irrespective of their infectious conditions. Here, the main role of nurses were to manage the isolation ward, and also providing the high quality services to the infectious patients. And my experience on this also, being a school health nurse, as a school were closed at that time, I was responsible to carry out to manage the isolation center at the rural areas, and there I should provide the health services to the infectious patients. And there were some shortage of the personal protective equipments, but also it was worth it because the patients were recovered and the target was met. And another most important role of rural healthcare nurses is providing the vaccination against COVID-19 and COVID-19 outbreaks. Like I was also responsible to provide the vaccination for the children aged 12 to 18 in my school. And likewise, other rural healthcare nurses who were working on the health post, primary healthcare centers, they keep the records of the vaccination provided, and also they provide the vaccination against COVID-19 to the individuals or the community of their respective working areas. And last but not the least, role of the nurses is to maintain the records and register all the services provided, including the birth and death of the people that are in the community, respective community. So all these are the key roles of the nurses working in the rural healthcare. And lastly, though it is somehow difficult to work in rural areas, but there is a satisfaction that you are contributing to improve the health status of your country regardless of any challenges that I have faced. So thank you. This much.
Thank you so much, Ms. Powdell. It was a wonderful presentation. And now for the closing message, I'd like to request Dr. Sudeep Shakya to please do the honors.
Good evening, everyone. We have come to the end of this rural healthcare session in APAN 53. It has been an honor and privilege to host this rural healthcare session in APAN 53. And on the behalf of the Kathmandu Model Hospital and the entire team, we would like to thank all the speakers who share their experiences. And we could see what's the status of the rural healthcare setting in our country. And we could also see how Dr. Dangal has done in his institution, and we can see that as a model. So I'd also like to thank Temdec for giving this opportunity to host this session. And also I'd like to thank NREN for the continuous support. And finally, I'd like to thank all our engineering team, Mr. Rosen also, without whom this meeting wouldn't have been possible. We look forward to see you in APAN 54, which I think will be held in China. Thank you very much and have a nice evening. Dr. Uday, are you there? No, I think.
Yes. Yes, Dr. Sudeep, it was.
Like to add, yeah, finally, would like to add something, Dr. Uday.
No, thank you. Thank you, Ali. It was very nice going. Thank you, Dr. Dennis, Dr. Zhang, Rasika sister, and also Pawan sir, Dr. Rajkumar. Everyone had a very good and excellent presentation. So we'll see you soon in APAN 54, and we'll be in touch. Thank you. Thank you very much.
Thank you. Bye
Thank
bye.
you.
Bye bye, Tomaiko.
Bye bye, everyone.
Hi there. Thank you.
Okay, thank you.
Thank you for cooperation. Stay safe, everybody.
Congratulations.
Thank you.
Thank you, Dr. Puja.
Thank you so
Have a nice
much.
day. Have a nice day. Bye-bye, Dr. Budaya. Roger, everybody.
Yes, Kumat, yours.
Yeah. Okay, Roger, thank you so much for your effort. to prepare the session.
No, you can't listen.
Okay, have a nice day. Bye-bye.
Ayan, oh, thank you very much. Yeah, ako pa rin ba? Sa mga tumong report,